Good afternoon, everyone. This is Eric, and I welcome you to today's webinar. Today is the Thursday webinar in the Biomedix Academy, and today we're covering how to perform the best quality test, the highest quality test for a variety of different points in the PADnet testing process. For those of you who are attending via our Zoom webinar feature, please feel free to click the raise my hand button in the Zoom webinar control panel to ask me any questions that, any questions that you'd like. I will address questions as I see them pop up. For those of you who are attending via Facebook Live, I would encourage you to submit any questions to our customer support phone line, 888-889-8997, or by sending us an email to support@biomedix.com. Because we're covering a topic, because we're covering a variety of points in the PADnet testing process and not just one topic, we'll be skipping around a lot today. For the arterial test, we'll be discussing some common challenges that technicians have with placing or using the PPG probe. We'll also be discussing selecting the return of flow and common challenges for taking waveforms and what to do about those. We'll also cover a common error in the arterial test called a non-compressible error. In the venous test, we'll discuss proper dorsiflexion technique, how to calculate venous refill times, and where to place your cuff. And then we'll also discuss a very common technical problem called a COM port error. Let's get started. So essentially the first thing that you're asked to do upon beginning the arterial test is verifying that there is a pulse coming from the PPG probe. So you should be able to see a regular pulse, you should see a peak, you should see a trough, and then that pattern, that up and down pattern should continue. It doesn't necessarily need to look exactly like what's showing in the top photograph here, the top picture here, but it should be regular. You should see that up and down pattern repeating and not repeating regularly, and it shouldn't look like a series of jagged lines like you see in the picture below. If you see that something along those lines, either the patient is moving, which is going to be a common theme of the webinar today. This is a test that's very sensitive to motion. So if you see that, you're going to have to ask the patient, you're going to have to stop the test, ask the patient to remain still, and then pick back up again. Alternatively, it's possible that based on where the probe is placed and how it's facing, that you may need to adjust the PPG probe so that light from the overhead lights isn't getting at that light facing sensor. If you're not seeing anything at all or otherwise are having trouble getting a reliable pulse from the PPG probe, the first thing you're probably going to want to check is whether or not the probe is plugged in. The computer is not going to prompt you if the probe is disconnected from the DTU. So if the response that you're getting is essentially nothing at all, like this top photo here, then that's the first thing that you definitely want to check. A common challenge with getting a PPG probe in the feet is that the toes may be cold, particularly among diabetic patients. When the feet become cold, blood contracts away from the surface of the skin, which is going to make it a lot more difficult to detect a pulse with the PPG probe, which only has a sensing depth of about 1 millimeter. So a lot of offices, and I definitely recommend this, to get the best quality test possible. A lot of offices leave the patient's socks on during the test just to keep those toes warm. And in some cases, I know offices leave a towel or a light blanket by that testing location to place them over the patient's feet and keep them out of the chilly air. Just like we mentioned on the last slide, if you are seeing some unusual results or aren't getting a strong pulse anywhere, there's a lot of artifact, you're going to want to check to make sure that there isn't light that's getting to the light-facing sensor. Because it's a light sensor and not a camera, it's reasonably robust. But if you notice that the sensing face, the shiny face on the PPG probe, has a big crack in it or anything along those lines, there's physical damage to it. That could be the reason you're not getting a valid result. And then afterwards, if you have a working PPG probe, light's definitely not getting at it, then what we may need to adjust is the location of the PPG probe. Now, my recommendation when you're taking the PPG probe placing the PPG probe on the patient's hand is to place it on either the first or the second finger, the pointer or the middle finger, on the first or the second knuckle, on the palm side up of the hand, the palm side of the hand. There are a lot of good places to get a pulse from the PPG probe. A lot of offices prefer to take the pulse on the pad of the patient's finger, which is a very highly vascularized area, which makes it easy to get a good pulse. The reason that I prefer not the pads of the fingers, the tips of the fingers, is because there's, especially among older patients, a lot of motion in those areas. There's just a little bit of there's often a little bit of shake there just because the fingers are sort of all the way out there by themselves and not being supported. Similarly, I know a lot of offices that like to place the PPG probe on the thumb. Again, that's also a very highly vascularized area. It's a little more stable than the tips of the fingers, so that's a check mark against it. But in my experience, because the thumb is often angled outward and upward, so to speak, light is more likely to sneak its way into that light-facing sensor. So I do want to highlight, I'm not recommending necessarily anybody change their procedure if you're having an easy time of it. When you're calculating those return to flow charts, you're having an easy time, there's not a lot of artifact, keep on doing what you're doing. But if you find a situation or a patient where you're having a hard time calculating those return to flows, it may be simply that you need to adjust the location. And I found the place where you're least likely to have artifact is the first or the second finger on the palm side of the hand on the first or the second knuckle. On the patient's foot, you're 99% of the time going to place the probe on the patient's toe, sort of a little higher up on the toe than, you're not placing it on the pad where you take a toe print. You're placing it a little higher up, closer toward the knuckle or the bend, the back of the great toe, so to speak. It can sometimes be difficult to place both the black Velcro from the PPG probe and the white Velcro from the toe cuff on at the same time. So if you're ever in a situation where you need both of those, feel free to remove the black Velcro, slide that up between the white toe cuff and the patient's skin. That we typically recommend the toe cuff, that the cuffs be placed directly against the patient's skin. That little non-compressible probe isn't going to cause you any difficulties with calculating the pulse or the waveform on the patient's toe. So, personally, that's how I perform most of these examinations. If you're not able to get the pulse in the big toe for whatever reason, it may not be well vascularized, it may be gangrenous, it may have been amputated. All of those are reasonably common in the kinds of patients that we're testing with the PAD test. You can detect a pulse in the smaller toes on the foot. That can often be challenging simply because there's just not a lot of room there, and many patients have toes that aren't large enough or tall enough to get the PPG probe face entirely covered by the patient. And if that's the case, we'll have another recommendation here. But in a situation where you can get the pulse and the patient's toes are large enough, that is definitely an option to get the patient's pulse in the foot. If you're not able to get the pulse in the patient's foot if you're not able to get the pulse in the patient's toes for whatever reason, then there are two alternatives in order to get the patient in order to take the pressure in the ankle. The first location in the foot where you can detect a pulse is called the dorsalis pedis, and you can and to find that, you can simply, moving down from the ankle along the arch or the top of the patient's foot, if you simply sort of drag your fingers lightly, you can often find that artery simply by moving your fingers lightly over the patient's skin. I personally often find it fairly challenging to detect that location. So the other location is the one that I typically use in these situations. It's called the medial malleolus. And to find that, you're going to want to place your three fingers together, your three primary fingers together, the pointer, the middle, and the ring finger. You're going to place the ring finger against the back of the patient's ankle bone on the inside of the ankle, and where the pointer finger lands is where those arteries run. So in that location, you'll find two arteries running side by side, sandwiching in between them one vein. So you have about a 2/3 chance of hitting that artery on your first try. You may need to adjust it a little bit to find a good spot for it. Obviously, the black Velcro isn't going to wrap all the way around the patient's foot or the patient's ankle. So our recommendation is to remove the black Velcro. You can either tape it in place like I've done here. You can use a double-sided tape that also works well. Just place the face of the PPG probe against one side of the tape and place the other side against the patient's skin. That'll work fine as well. Some offices have sort of a surplus of Coban wrap, and feel free to use that as well. Simply wrap that around the probe and keep that flush with the patient's skin. You should have an easy time of it. We're going to move on to the next portion of the webinar, which is selecting the return of flow. Now, I want to highlight here that oftentimes we'll get calls and they'll say, yeah, we've seen the demo waveforms, the demo return to flow charts, which is what we're looking at now, but our waveforms look all over the place. They're crazy. I don't know what's going on. They don't look as nice and neat as this one. The reason for that is usually the placement of the PPG probe. So if your return to flow charts are all over the place, then then we're going to talk about not necessarily looking at the return to flow chart, but looking at the instead looking at the placement of the PPG probe to possibly remove some artifact and get a cleaner test. As far as calculating the return of flow trace, what we're looking at here, and I like to spend a little time discussing what's actually going on with the test, because I find that it makes it selecting what you're looking at a lot more intuitive. What we're looking at with these return to flow traces is essentially the same thing that you're doing when you're taking a manual blood pressure with a cuff and a stethoscope, except rather than our stethoscope, we're using the results from the PPG probe to detect that location. So when you think about it that way, this chart starts to make a lot more sense. On the left-hand side, where the pressure is very, very high, the limb is occluded. There's no blood flow going through that arm or that ankle. And obviously the PPG probe on the finger or the toe isn't going to detect a pulse. Similarly, on the right-hand side, the cuff is very loose. It's not restricting blood flow in any way. And what the PPG probe is showing there are great big pulses from the blood that's flowing through that location. So just like with the stethoscope method, our interest is more towards the middle. We're looking for the very first time that a pulse manifests itself on this trace. And again, just like with the PPG probe, you should be able to see a peak, you should be able to see a trough, and you want that pattern to continue as the cuff loosens as you move from left to right. So on this demo study, it's pretty easy to see where the first actual pulse is. I've highlighted it with the big green arrow here. Right there where you can see a strong up, you can see a strong down, and that the size of that pulse increases gradually as the pressure on the cuff loosens. I also want to highlight the blue box that I've highlighted in the bottom right-hand corner, where it currently says 77 millimeters of mercury. That box, that location that I've highlighted, shows you where the pressure is, what the pressure is, where your mouse is resting. So as you move your mouse up and down that flow chart, you can see the pressure that your mouse is currently hovering over in that blue box. That'll be essential in just a second here for one of the sort of advanced techniques that we're going to talk about here. I did want to take a second, though, to show a second study. Often we, especially in the arterial webinar, because we have so much material to cover, I can't show you several charts to show some variation. So this is a more real-life study and is probably a little bit more closer to what you're seeing on a return to flow trace. Now, there are a few differences, but there are also a lot of similarities that I want to highlight. You can see that, broadly speaking, the shape or the form of the waveform looks pretty much the same. On the left-hand side, where the cuff is occluding the limb, there's not a lot of blood flow and therefore no pulse. And on the right-hand side, despite a little bit of up and downness going on, what we're seeing is generally great big pulses that repeat as you move from left to right. So just like on a previous chart, where we're looking is where we see the first actual pulse. I've highlighted it again with the green arrow. There's a strong up, there's a strong down, and that pattern repeats itself. I want to highlight the location that the location where the red arrow is. It's not uncommon to see sort of big jagged lines that occur in these sorts of traces, and a lot of technicians find those very alluring, right? That it's a very obvious feature of the chart. It's a very clickable location. So I find a lot of technicians want to select spots like those as the return to flow, despite the fact that after that big sort of jagged up and down, it goes right back to the compression like it was to the left. What we're actually looking at with that red arrow is a blood spurt. As the cuff compresses, or rather, as the compressed limb decompresses, as the cuff releases some pressure, the body often shifts around a little bit, physiological speaking, which can release some blood that's essentially trapped by the pressure in the cuff. So that's a blood spurt. That's not an actual pulse, and it's not a good indicator of where the flow returns. So we're really looking for that pattern, up, down, and we want that pattern to continue from left to right. If you're in a situation, maybe on like this one, on this trace, where you're unsure about where the flow actually returns, you can ask for the computer for a second opinion. Now, the computer's judgment is pretty good, but it's not perfect, so I definitely respond, I definitely lean towards the side of the human if there's ever a disagreement. But if you're operating a test, you're by yourself, you want a second opinion, the computer's available and happy to provide that for you. What you're going to want to do in that situation is you're going to want to move your mouse up and down the trace until you find the location where you think that flow returns. That shows in the box in the bottom right-hand corner here. It looks like I have selected 135 millimeters of mercury on this particular test. What you're going to want to do is you're going to want to find that pressure, keep it in mind, and then you're going to want to click Can't See Return of Signal. What Can't See Return of Signal does is it gives you the computer's guesses to the systolic pressure. If the computer's guess matches with yours or is within a few millimeters of mercury there, that's great. Move on with the rest of the test. If the computer disagrees wildly, more than 10 or so, then you're probably going to want to redo that study in order to get your data more in line here. I did say this would be a feature of the webinar, so I just wanted to show you what it looks like if the patient's sort of excessively jittery or moving a lot during the test. You can see about a quarter of the way along the line that the jagged up and down pulses that we're seeing here from the PPG probe sort of grow in amplitude, but I would not at all feel confident about selecting the return of flow on this one. So at this point, if I was presented with this trace, I would maybe adjust the PPG probe to get a slightly snugger fit, but probably just advise the patient to remain as still as they can during this portion of the test and redo that pressure test. At this point, we're going to move on to the waveform portion of the webinar. There are a couple of, we're going to talk about in a little more detail what it looks like when a waveform is showing something other than what it's supposed to, if it's showing artifact from the testing procedure rather than those nice clean waveforms that we're looking for. But first, before we did that, I wanted to go into a little detail on what we're actually looking for in those waveforms. What we're actually looking at in these waveforms is literally the artery in the patient's legs expanding and contracting as blood passes through them. So on the left-hand side, there's a pulse, there's a heartbeat, there's a rapid expansion of that artery to accommodate the increase in blood flow. That's because these healthy arteries are very elastic, they grow very, very quickly. So that's that steep upslope on the left-hand side. Now, the artery quickly reaches its maximum size. It's quickly expanded to as large as it can get, and then it just as quickly begins to contract. Again, they're very elastic, almost balloon-like in their ability and willingness to expand and contract. That contraction begins very quickly, so that the peak at the top of our waveform is typically very, very narrow in a healthy patient. The contraction is also, again, very swift, very dramatic, and so you'll see a steep downslope on the right-hand side of these waveforms as well. The arteries are in fact so elastic that as it contracts, it actually rebounds upon itself, creating that little bump out or dicrotic notch on the right-hand side. So again, we're looking for a steep upslope, a narrow peak, a steep downslope, and that dicrotic notch. That's an indication for a healthy waveform for a patient. You can see all of those features on the graph that I've selected. Some other things that we're going to want to do as best as we can to provide the best information for the doctor that we can, is we want to try to fit as many waveforms as possible on a screen. Now, in an ideal situation, we'd be able to fit 3 waveforms on the screen, like I've done in this picture here. We have 3 beautiful waveforms start to finish. Depending on the patient, that may not be possible. I've seen patients where you can only fit 2 waveforms on a screen. I've even seen patients where it's only possible to fit 1.5 or so. And in that circumstance, you just try to get as many waveforms as you can, and you want your waveform to be a model or an ambassador, so to speak, for the other waveforms that we're not able to fit on the screen. We definitely want to make sure that the waveforms have an even, consistent amplitude, which means that the peaks and the troughs are at the same height. Those waveforms are level. Now, obviously, the ones in this demo study here are straight as a ruler. Now, that's often a little bit unrealistic in an actual patient because tiny things can throw off those measurements. But sometimes, and we'll see later in the webinar, we'll see waveforms sort of climbing across the screen or descending across the screen like they're going up or down a set of stairs, and it's definitely something that we want to avoid. We're also looking for very smooth curves. Sometimes you'll see some unusual waveforms that are boxy, jagged, something along those lines, and that's, again, not something that we're looking for. That's typically artifact caused by movement. We'll see a couple of those webinars, a couple of those waveforms in a few minutes here as well. The last feature on it is that dicrotic notch, which we talked about, but I just wanted to highlight that's where that red arrow is pointing on our waveform. That's our dicrotic notch. And the reason that that's so important is because that dicrotic notch is essentially a canary in the coal mine for the patient. It's real when a patient begins to develop a peripheral artery disease, the very first thing to go is that the artery's willingness to rebound upon itself as it expands and contracts. That's that dicrotic notch here. So you'll often see patients who have mild PAD, and they have strong ups, they have narrow peaks, they have strong downs, but they lack the dicrotic notch. And I want to highlight that those patients are sick because they're missing that dicrotic notch. One of the first challenges that I often find that technicians have in performing the study is they simply don't wait long enough. It does take, as the cuff pressurizes the leg, pressurizes the cuff around the leg, it does take the body a few seconds to accommodate that and sort of settle down after that change. And so you'll see waveforms that sort of climb across the screen or descend across the screen very, very early. And again, it should take 5 to 10 seconds or so before the waveforms appear, and it may take another 5 seconds or so before those waveforms sort of settle down and become nice and even like we're looking for. So you'll often find, again, we'll see not smooth curves as the legs settle down. We'll see the waveforms of different sizes. You can see in the top, this top picture here, we have one waveform sort of a third of the way across the screen and a second waveform that's much, much larger. And we don't know which one of them is indicative of the patient's actual physiological state until they settle down and we start in the system, we start looking at a particular level. Another issue that can arise is we definitely want, in 99.9% of cases, we definitely want the cuff directly against the patient's skin. If you can imagine what we're doing here, we're inflating a cuff and we're using the volume of the patient's leg to examine blood flow. So as the patient's heart beats, their leg literally expands a little bit, which pressures air out of the cuff, and that's how that increase and decrease in pressure is how we gather these waveforms. So if you can imagine how difficult it is to examine an artery inside the patient's leg using this method, you can imagine how much more difficult it becomes if there's a barrier in the way, like denim, or if the cuff's not tight against the patient's skin. It's just going to be very difficult for the system to get an accurate reading on what's going on inside the patient's leg. So these waveforms will often be very, very small. They'll often be very dampened. They'll often be very rounded because we lose a lot of the detail on what's going on with the patient because the cuff's not flushed with the patient's skin here. No section of our webinar would be complete unless we had a slide about what it looks like when the patient's moving. You'll often see waveforms of vastly different sizes. Things will go up or down with no reason. You'll get jagged lines, very tiny waveforms, very large waveforms. Honestly, I can't tell exactly. In the top, for example, it looks like we may have one larger waveform on the left-hand side with maybe a dichrotic notch, and then a very small one on the right-hand side. But because the patient's moving, I can't tell what these waveforms look like. One feature of the one other piece of control, well, let's talk about it this way. One of the features of the PADnet system that's new as of our current version of the device is that the amplitudes are measured by the computer. In previous generations of the device, the technician needed to spend some time during the test to measure those waveforms. Now the computer does that for you, which is very helpful. But one of the side effects of that is that in order to measure the waveforms need to fit on the screen. If it's not doing that, if the waveforms are going above or below the screen, the system's not going to be able to capture those waveforms and it's not going to be able to measure them. So in that circumstance, you are empowered. Technologists should feel empowered to reduce the gain on the waveform, which will allow that waveform to fit on the screen and will allow the computer to measure it. That is the only situation in which you should edit the gain. I know there are a lot of technicians. We get some of the interpreting physicians send us tickets about non-diagnostic tests that can't be used and aren't clinically valuable. And one of the most common reasons is that technologists change the gain to be larger or smaller for no discernible reason. They just change it. The only situation in which you should do that is if the waveform is too large to fit on the screen. Now, I do want to highlight, though, that if you're in a situation where you need to reduce the gain on one leg, you're also going to need to go back and reduce the gain on the other leg. If we assume that the top picture is the right leg and the bottom picture is the patient's left, then if an interpreting physician looking at these two legs is going to say, well, the right leg is fine, but there's something definitely wrong with that left leg because the amplitude's so much smaller. Now, in this case, they're not only both fine. The bottom picture is actually the same waveform as the top. It's just made smaller by that gain. So if you're in a situation where you need to reduce the gain on one leg, you need to go back and change and redo the test on the opposite leg to make sure that those gains match, and the interpreting physician is comparing apples to apples. This is another common occurrence in the testing software. It's called a non-compressible error, or a non-compressibility error. This typically occurs in the patient's ankles. It's very rare that this occurs in the patient's arms, and it occurs most commonly in patients that are diabetic, patients that are highly hypertensive, or both. What's going on in those patients is that there's often vessel calcification in the ankles. And so essentially, rather than having that expansion and contraction of the artery that we were talking about a moment ago, they're almost lead pipes. They don't expand or contract, and they can't be compressed because of that calcification. So what this error actually means is that the system tried its hardest to get a pressure there and wasn't able to. The system has a maximum pressure of 200. So the solution to that is to enter a manual pressure of 201. That's an indication to the system, the computer, and the interpreting physician that you weren't able to get a pressure in those at that location. What setting it as 201 does is it will actually, you can see here on the PADman that it literally displays as 201 NC for non-compressible to signal to the doctor what's going on in the leg. Now, obviously, at any time you're unable to get a pressure, unable to get a piece of data, you're going to want to place in the notes why that was. You know, if you don't submit a right toe to the doctor is going to want to know why, even if the patient, for example, didn't have a toe. So if you're not able to get a pressure in this location, just mention that the patient is diabetic or hypertensive, and that and that you weren't able to get a pressure in that location. Now, you also use the same procedure to skip that test if the patient, for example, has had a below-the-knee amputation on one side or the other, and you're going to want to obviously mention the reason why you didn't get that data to the interpreting physician as well. At this point, we're going to move on to the venous test. Probably the single most common difficulty with the venous test is simply that technologists don't know how to calculate the refill time. It's pretty easy. Just talking about what this test is doing, on the left-hand side, we have big, strong dorsiflexions where blood is evacuated out of the patient's leg. And then there is after the patient performs those dorsiflexions, you have the patient stop and rest. At that point, the point where they stop performing dorsiflexions, that's your first point where you select the refill time. So at that point, that starting point is always going to be the lowest point on that trace, the southernmost point on that trace, and then the end point where you stop stop calculating the refill time is where the trace crosses that top bold red line. There are two bold red lines with a yellow box. You can see it on the screen. The top red line is the patient's baseline. And so once the trace returns to that line, the patient's done refilling, and we're ready to go onto the next leg or onto another test. You can see here that this patient has a refill time of about 16 seconds. The difference between a normal and an abnormal refill time is whether or not it's above or below 20 seconds. So in this case, the patient has a refill time of about 16 seconds, which does indicate mild to moderate venous insufficiency. The one sort of pardon me here. The one exception to that rule is there are some patients that, for whatever reason, don't return to baseline the way that the system is expecting it to. What will happen is that the patient's trace will refill, but then it'll level off at a location below that top red line. So in that circumstance, you're going to want to pick the point where the trace stops increasing. Typically what I do is I'm looking for I'm watching the trace go up and looking at which boxes it passes, and then I at a point where it no longer is moving up along the box line, that's the place that I pick here. This patient has a refill time of about 21 seconds, which generally indicates a healthy leg here. Another common problem with this test is that patients don't perform dorsiflexions properly. It's not an intuitive motion for a lot of patients. It's not an intuitive thing to do. And so I did want to take a second to talk through dorsiflexions and coaching patients on how to perform them. So cast your mind back to the posture for the venous test that we went over on Tuesday. You're having the patient perch on the edge of the chair with their butt as far forward as they can get it, back straight, testing leg, typically the right leg first, extended at a greater than 90-degree angle. The left leg is at about 90 degrees, and the toes are both parallel and pointed forward. At that, when you're going to start the test, the cuff will inflate. The system will prompt you to have the patient begin the dorsiflexions. It'll flash in bright yellow. When that happens, you have the patient leave their heel on the floor, lift their toes in the air, and force their toes back down like they're operating a kick drum. That's one dorsiflexion. You'll need to perform 5 to 10 until the leg is properly evacuated. There are some patients may not be able to perform a dorsiflexion. In that case, you can use a heel lift as an alternative. If you if we think back on that posture, it's essentially the same motion, but in reverse. You have the patient leave their toes on the floor, the ball of their foot on the floor, you have them raise their heel, and then they force their heel back down. They don't evacuate blood quite as well in dorsiflexions as our experience, but they do still work. Just like with the gain changes that we were discussing a couple of slides ago, though, if you're instructing a patient to do heel less on one side because they can't make that up and down motion, you're going to want to make sure that they're performing the exact same motion on the other side, so we're doing an apples-to-apples comparison. Probably the most common difficulty that patients have with the dorsiflexions is they're simply not performing those dorsiflexions vigorously enough. I meet a lot of patients that perform tests like this one that are they're sort of tapping their toes as if they were, humming along to a holiday special here. And that's not what we're doing. This is a vigorous exercise. It's a forceful exercise, and we're using the muscles in the calf to evacuate blood out of the leg. So if they're not engaging those muscles, obviously we're not going to get a lot of evacuation. It's pretty visually striking. The difference in the size of the dorsiflexions on this trace compared to the dorsiflexions that we were looking at over here. The dorsiflexions on these are much, much larger and are obviously evacuating a lot more blood out of the leg. This is giving calculating it properly here from the end of the dorsiflexions to the point where it crosses that baseline, gives us a refill time of about 4 seconds. Now, I'm not going to tell you that a dorsiflexion, that a refill time of 4 seconds is impossible, but it would indicate a very, very, very sick patient. So if I saw something like this with a 4-second refill time, the very first thing I would check is whether or not those dorsiflexions are evacuating blood out of the leg properly. And most of the time, the blame, so to speak, would be with the test quality and the exercise that was performed, and not with the wellness of the patient. Another common thing I see with technicians is that there are some technicians that like to place that cuff very, very low on the leg, sort of on the ankle going up the calf rather than the widest, thickest, most muscular part of the calf going down. And we do want it at the widest, the most muscular part of the calf. That's where there's a lot of blood flow. That's where there's a lot of cross-sectional area, both of which are a little bit lacking around the ankle, which is typically much smaller and much narrower. Another facet of this I wanted to highlight is I see a lot of technicians that only use the venous sense cuff to perform studies. Now, the venous sense cuff works great. There's no reason that you shouldn't use it. And it makes sense to use that, given that it matches up nicely with the venous sense cuff port on the device. I do, however, want to highlight that there is another cuff that works equivalently with the venous sense cuff. One of the challenges that I find when using the venous sense cuff is that because it is a larger cuff, it's designed to accommodate patients with suffering from edema or simply patients with larger legs. When I test a patient with a slimmer leg, like my model in this picture here, there's, it's often very difficult to get a good fit just because it's such a large cuff. So if you're in a situation where you're testing a patient with a slimmer leg, I personally find it a lot easier to use that smaller cuff, the arterial or calf and arm arterial cuff from the arterial test. So this is what it looks like when the patient is, when that cuff is too low on the leg. Now, unlike the toe tapping holiday special patient we were looking at 2 slides ago, these dorsiflexions look a lot more dramatic, but what they don't do is evacuate very much blood out of the leg. Doing just a quick comparison between this dorsiflexions, where we're moving way up and moving way down below the baseline here, comparing that to these dorsiflexions, they're a lot more pronounced, but we're not evacuating a lot of blood. The reason for that is that there's just not a lot of blood. There's not a lot of cross-sectional area in the ankle, which means you're not doing a very good study of what's going on with the patient's blood flow in and out of the leg. This is another common one I see with patients. They simply start the test, and again, a healthy refill time is 20 seconds, and then they stop it early. This to me looks like a perfect study, far and away the best of the studies that we've looked at, except for maybe the first. We have great, big, strong dorsiflexions on the left-hand side. We've got a lot of blood evacuation. The refill time is selected properly. And then 13 seconds into the refill time, the technician stopped the test. I don't know why. And honestly, I can't tell you whether or not this patient is sick or not based on the refill time, because it doesn't get back to baseline. It doesn't level off. I don't know if the leg's done refilling at this point, or it's going to take 10 or 12 seconds or 15 seconds to get back to baseline. So if you see an example like this one, there's nothing else for it but to redo the test or this portion of the test. And then just to show you what it looks like if the patient is chatting during the test, I don't exactly know what's going on with this study. It's possible that those big jagged up and down lines are dorsiflexions, but it's more likely that the patient's moving or talking, or I don't know. You simply have to redo this study to get any valuable testing data out of it. This is a very common, this is probably the single most common call we get at Biomedix. It's an error called a COM port issue. And this issue occurs, the reason for this, you've got the patient on the table, you've entered all of the demographic information, you move to click perform, and you notice that there's a red box there that isn't typically there. You click perform, it takes you to the pressure, and the start button is grayed out, so you can't start the test, and that box is in bright red. What that box is indicating, both here and in the actual test itself, is that the computer isn't receiving instructions from the device that actually inflates and deflates the cuffs and measures those changes. This is, like I said, a very common situation. The device is on a cart, and the cart is often moved room to room. So what the most common explanations for the red box or the COM port error are that the device isn't plugged into the wall. The device is not turned on, so you can't see that green light there, or the cable that's connecting the device and the computer has gotten disconnected. In those circumstances, obviously what I'd recommend is reseating all of those cables, making sure the device is turned on, close out the PADnet software and reopen it so that the software sees those renewed connections with the computer and you're ready to go. If you've checked all of those connection cables and everything seems to be turned on, everything seems to be plugged in securely, it's possible that the computer has simply, essentially forgotten where it's supposed to be receiving instructions from the device. Again, that's not uncommon if because the device is plugged and unplugged all the time, moved from room to room. Sometimes office technicians plug in their phones to recharge from the computer, things of that nature. So if the computer, you're sure everything's turned on and seated properly, what you're going to want to, there's one other thing that you can try, and that's if you go up to admin in the menu settings on the PADnet software, you go down to office settings, there will be a pop-up, and in the top left corner of that pop-up is a drop-down menu labeled DTU port. Click on that and make sure that there's something selected in there. Most commonly, that something is listed as COM3, but if it lists as another number like COM4 or COM8, that's perfectly fine. Select that, click OK, and you should be up and running again. If it says something other than COM3, I've seen all the way up to COM20. It just varies based on what that laptop is used for on a typical day-to-day basis. So select that, click OK, and then you should be back up and running again. At this point, we are nearing the end of the webinar. We've covered all of our topics for today. So for those of you who have questions, I encourage you to click the Raise My Hand button now to ask me any questions that you'd like me to cover before the end of the webinar. I wanted to take a few seconds here to highlight a couple of special offers that are available through Biomedix at this time. The first one of them is technologist certification. Most states and most insurance companies have a requirement that technologists performing these certifications are certified through a nationally recognized body. At Biomedix, we are happy to provide you those certifications through a program in partnership with the American College of Foot and Ankle Orthopedics Medicine, or ACFOM. Previously, we used to charge for these certifications, and that we found that was preventing some locations from testing because they didn't want to test with an uncertified technician, and they also didn't want to pay for those certifications. So we've got a new protocol here. The first step to getting, which is free of charge for everyone operating under PADnet's contract. The first step will be getting trained. Training for the certification can be purchased, but more typically involves the attendance of the webinars, like the one that you're at today, or by reviewing the webinars, the recorded webinars on our YouTube channel. After training, the technologist will need to take and pass an online exam to show, mastery of the material. After they've passed that exam, they're considered sort of provisionally certified under the supervision of the doctor. During that probationary period, they'll have 30 days to complete 10 studies on 10 real patients. We'll review those to make sure that there are quality tests being performed, and then issue that 12-month certification at that time. Once the 12-month certification is up for renewal, as long as you've performed at least one study a month in that intervening 12 months, then we're happy to pay for the renewal of that certification at no cost to you. If you've missed a month, maybe you're sick, maybe you're on vacation, all you need to do to get back in compliance is complete 5 studies on the following month. Another free service that I wanted to highlight, and this is the first thing that I mention whenever anyone asks me that they'd like to use the test more often, they'd like to test more often, they'd like to test more patients, they'd like to use the device more. This is a great service to sort of enable that. At your invitation, we will remote into your medical record system, your electronic medical record system, and create a pair of reports out of your patient history. The first report will be indicated patients. These are patients that have already been tested for the that already have an indication to be tested for the PADnet device, and gives you the these patients can and should be contacted to be scheduled immediately for the PAD test. The second list is a list of patients with common risk factors for PAD. These will be patients over 50 with a history of diabetes or smoking, patients who are hypertensive, patients who are have a history of arterial sclerosis. All patients over the age of 70 are all very, very common, very, very likely to develop or have PAD. That list is typically 5 or 10 or even 20 times larger than the original list. And those patients should either be presented with a questionnaire to determine whether or not they have a symptom that means they should be tested for PAD, or or they should be assessed with our vascular assessment protocol that we discuss in our Monday webinar to determine whether or not to screen them for PAD and evaluate them that way. If we find at least 100 patients, and I'll tell you, I do several of these a week, and we always find at least 100 patients, we'll provide you with a free month of service at the same level you're already operating under. The last special offer I wanted to highlight through Biomedix right now is we've recently developed a physical upgrade for your existing devices. The upgrade is called Security Vault, and it's this little box here on the screen that sort of plugs into your existing device. There are a lot of features on this. It allows you to test more securely, as the name implies. It also allows you to test more quickly. And it allows you to upgrade to the most recent set of ICD-10 codes. I know operating on those 10-year-old ICD-9 codes in some cases can cause a lot of headache for a lot of people. It also, for sites that want to read their own studies or want to interpret their own studies, it also provides a free read license. Typically, that is something that you guys would pay for, and that gets omitted in a situation where you own or have purchased a Security Vault. And it makes your testing device agnostic. Typically, with the PADnet device, you're sort of shackled to that PADnet laptop. And in this circumstance, with the Security Vault, we've omitted the need for that entirely. Any device, any phone, any tablet, any computer with wireless capabilities can perform a test. I've performed, I've just used my cell phone that I use day to day to perform a test. It's very slick. It's very convenient. It makes things, I think, a lot easier and a lot faster. So anybody who's attending who's interested in upgrading to the Security Vault or has questions about it, I encourage you to give us a call at 888-889-8997, and we'd be happy to discuss it with you. At this time, I am going to open up the webinar for questions. So I didn't get any here, but I'll wait just a moment longer to give anyone with a question the opportunity to raise their hand. Okay, since there don't seem to be any questions, I look forward to seeing everyone for the final day in the Biomedix Academy tomorrow. It's an advanced topics webinar. Because it is Friday, it's a little bit of a shorter webinar. We mostly discuss contraindications on patients and what you can do to test the patient to the best of your ability. And then just a few last tips and tricks with the device that you may not be aware of, just to sort of round out your PADnet experience. I look forward to seeing everyone tomorrow, and I hope I appreciate you for attending today, and I hope everyone has a nice rest of their day. Thanks for attending.